Hi, this is Kim Rigger, and this week's assignment was to report on an improvement project, and I chose the one that I'm currently working with. It's the Emergency Department Stat Lab turnaround time. We have a lot of problems with this, and so I wanted to let you know why we feel this is important. Lab delays result in a lot of decreased patient and employee satisfaction. The delays are throughput and quality care, and all this negatively impacts our hospital revenue. The average per capita healthcare costs are nearly twice that of other developed nations, which forces those in healthcare to closely scrutinize how their organization is functioning and where additional efficiency can be gained. That came out of a 2015 study by White, Barron, Diggy, Camargo, and Brown. We found that very interesting because in this day and age, we all have to be very aware of what costs we are expending and where we can recapture and regain some of that revenue. Hill Country Memorial is a Baldrige Award-winning five-star organization that always strives to be no less than top decile in all benchmarks. This is extremely hard to do when you're a rural facility with limited resources, and every dollar counts. So our shared vision at Hill Country Memorial is to be remarkable always. And this is one way that we can make a remarkable difference in the lives of our patients. Our shared leadership goal is one thing that we did this year. We all have goals that we have. They're called LEM goals, which is a leadership evaluation management goal. And we use that goal to keep us on task and to all share the same vision. So for all of us in leadership, our goal is to reduce the emergency department turnaround times for admitted patients to 180 minutes or less and discharge patients to 94 minutes or less. That would put us in the top decile for all size hospitals. Now that's something huge because big universities all the way down to critical access hospitals are making an impact on our times here. Reasons why we chose this, well, of course, improve patient safety. That always has to be at the top of everybody's list. And along with improved safety comes improved quality of care, patient satisfaction, employee satisfaction, cost containment, and we have to always think about those publicly reported times. And for the emergency department on hospitalcompare.gov, median time from ED arrival to ED departure for discharge and admitted ED patients is something that we have to publicly publicize. And value-based purchasing is, of course, based on that. So for 2018, our turnaround time goals for HCM ED patients, admissions 180 minutes or less, which puts us in the top 10th percentile, like I said. But as of 2017, our year-to-date admit turnaround time was 192. We have 12 minutes to go. That is just a little itty-bitty bed, but it's something that we have struggled with the entire 6-7 months that I've been there so far. Discharges are at 94 minutes, that's our top decile goal, and in 2017 it was 137, so that gets us behind the ball by about, what, 46 minutes or so? 40, yeah. Then again, in our lab turnaround time project, our SMART goal, because we all have to have a shared SMART goal, is to decrease our lab turnaround time for ED ordered complete metabolic panel, which is at CMP, and the cardiac injury panel, which is a CIP. That's where you're going to get your troponin. We need those in less than 30 minutes in order to reduce our overall length of stay. The LOS is length of stay for both admitted to the 180 and the discharge to 94 or less using our internal diver reporting system. I've talked about that diver reporting system in several of my other products that I've put out, and it just happens to be our internal analysis tool system that we use. It's a computer program. It takes all kinds of data points out of our electronic medical record and then creates these system analysis reports for us. The goal that we will be achieving is that over the course of 2018 is our reported year-end median turnaround times will be successfully met for that 180 and 94 minutes. Median is used because there's always some kind of outlier out there and it can skew your averages. Timeline door to discharge is, as I showed in here, it's a continuum. So we give our doctors about 15 minutes to get into the room. That allows for our very busy days. When we can, we swarm, which means that the doctor, the nurses are all in there at the same time when the patient first arrives. Doesn't happen all the time, so that's why the 15 minutes. And then on the back side, we give our nursing staff about 15 minutes to prepare the discharge paperwork And so that takes 30 minutes off of that 94 minutes. So it only leaves 64 minutes for that provider to make that decision. That's why I put the little Kaizen drop on top there, the little star thing, and that's where we can make our impact. So I said on the bottom here, the overall door to discharge turnaround time of less than or equal to 94 minutes is where we can make our biggest improvements. Quicker access to test results and critical decision making, that's where our obstacle comes in. And I did also indicate that our door to provider and decision to depart times have already been set by HCM as best practice. Then I also included it again for our door to admit departure. On the back side, the decision to depart has been defined if we can make it out of the ER in 42 minutes and get, again, the door to the provider down to 15, that would leave us 123 minutes. So about 2 hours in the middle to make that decision whether our patient's going to get better and be able to go home, or if we're going to have to keep them because we have not been able to make their condition turn around in the amount of time we had. Again, the times on the bottom are set already. So what do we do to do that? So plan, do, study, act. That's just a process improvement model. And I showed you a picture there on the right-hand side where it's circular. It keeps going round and round. As soon as you think you have it all figured out, you've got to keep now analyzing it and make adjustments and then keep studying and doing and refining again. So some of the tools that are available for us to use in the healthcare world or any other world are included here on the left-hand side. Gap analysis worksheets, PDSA planning worksheets, project management worksheets, all three of which I completed to come up with this PowerPoint presentation. There are national benchmarks available, best practice, process mapping tools, and other Lean Six Sigma analysis tools. And when I looked at that, I thought, okay, well, we're not manufacturing, but the product that we manufacture in healthcare can be equated to timely, accurate, and empathetic medical care. This is the resource from 2010 where I found that. For my project, the team member roles and responsibilities all come along. We have myself, the lab director, Eric. Jeff, he is our Lean Six Sigma mentor. Mike Reno is Eric's boss, our COO, and he's also our project champion. And then the patient flow team. This is a shared governance hospital, and so we have to also include all of our frontline staff in some of these major decisions that we make. And on the right-hand side, I listed their responsibilities. Myself, I'm doing most of the data collection, evidence-based practice, and the research, just because, with school, that makes sense. And also, that's something that I have a little bit more education in than the other people on the front line. Eric has to monitor his lab. He has to focus on his own evidence-based research and benchmarks that are available for him. Process improvement within his own department is really important. He needs to get his team on board and get them involved with making these changes. Jeff, he helps us a lot with the Gemba walks, which is where you do all that time mapping, find out what has value, what does not have value, and he's helping us a lot with that right now. Responsible for keeping our team on track would be Mike. He has to also be the person that we go to if there's FTE considerations or other financial resources that we might need. He's also the conduit to our executive team and other high-level decision-making actions that may be required to make this successful. And then our patient flow team, they'll review our recommendations from both the lab and the ED teams and evaluate how it's going to impact their departments and the care that they provide. In my gap analysis, which is the planning phase, I had to determine what aspects of what practice we'd like to improve. And that overall is the stack turnaround times for those two particular lab tests. Determine what the gaps are between our current and future state. And I do have a slides coming up that will show what I found. And so we only picked the two tests because those are the two that also impact other time-related parts of our ED turnaround time. So with the CMP, that gives us our creatinine. So if we need to have a CAT scan that requires the IV contrast, we need to have that. And then the CIP with the troponin, because you need door to cath lab or door to thrombolytics, is extremely time sensitive when you're having a STEMI. We also needed to determine the factors that were responsible for those gaps. If we understand the expectations, there's been no recent time studies done for minimal process times. There were no benchmarking standards found. There are a lot of communication gaps and a huge lack of buy-in and inconsistency, competing priorities between all of our departments. What else could be done to remedy these listed factors? Well, best practice resources. Enhancing communication is always at the top of the list. We need to get the team buy-in. We need to do new time studies, share common goals, and evaluate our peak demands versus our staffing. Resources available, again, the lab diver reports, the ED turnaround time reports, our shared LEM goals, those leader evaluation management goals that we all now have this year, and then contract performance metrics. This year we also built into our physicians in the emergency department turnaround time goals for them as well. Resources we need are our Lean Six Sigma consultation. We did get a pneumatic tube system last year, and so that has greatly reduced our times, but we've not studied our times since that has been put in place between the ER and the lab. We do have redundant forms of communication, and we need to be using those, and possibly needing additional staff at certain times of the day. So here's my change plan. I started this a while back, and so I've had a little bit of the data already inputted into it. But first we need to determine our lowest reproducible turnaround times for CMP and CIP in our current state. And as of just the 14th, we did determine the CMP can be done within 17 minutes from the time it's received to the time it's resulted. And a CIP can be done in 15 minutes. The range was 11 to 17. So establishing a benchmark for those achievable timelines, we know that we can do them less than 30 minutes for the actual runtime. CMP runtime is 21 altogether, and then the CIP benchmark for 30 minutes or less is achievable, and a CIP can be run in 20 minutes or less. So we do have 10 minutes of play in getting that specimen to the lab. We need to develop and implement our action plans to meet our future state. Right now, we're evaluating all the outliers for the whys, and we're focusing our efforts on orders to received. Next is educating our staff and implementing identified action plans, aligning our patient flow team with the future state. We need to track our progress, share our results, reevaluate our new current state, and revise to reach a new future state should it not be to the point that we want it to be or need it to be to reach our year-end goal. And then we need to revise policies and procedures to match our new best practice. So our next step, we've completed the top 3. Our Gemba walks are now done. Our data analysis from those Gemba walks is done. We've established benchmarks. Next, again, to reach our action plan, this is our do, study, act portion. We're going to educate the staff and implement our action plans. Our patient flow team will get aligned. We'll create a dashboard for reporting. We're going to evaluate and reevaluate, revise as needed, and then revise those policies and attach deadlines to go with all of those. It's not going to be super fast because there's a lot of moving parts, but we do have a plan in mind that's fairly short. I mean, it's over a course of 3 months, so over a quarter of time we should be able to get this managed. Change is very hard for some, and so there's that culture change that we have to work through. And I found this little chart in one of the AHRQ government's websites. That's the for the advancement of healthcare research and quality. So we have to acknowledge that just change is hard. There are going to be challenges that you have to face, and so you might as well bring that to the forefront right away. So there's culture change, there's staff resistance, and there's the staff resistance along with culture change and lack of resources, and then just the lack of resources as well that causes staff resistance. So being aware and addressing it from the front will help us manage some of that along the way. Here's our current state process map. So our patient arrives, and I focus strictly on the POV, which is the privately owned vehicle arrivals. EMS patients often come with their IV already established, so that does change the process just a little bit. But for the ones that come in, the majority of time, they're coming in by our front door. So the patient shows up, they present themselves to the registrars, who gets their basic information of their name, their age, and their chief complaint. They have them sit down in the lobby chairs, and then they announce over the walkie-talkie what information they have. They, of course, don't say the name, but it's the age and the complaint. At that point, the sitting in the lobby is always going to be an issue. You know, anytime you make somebody sit, you tend to increase your length of stay. So if we could eliminate that would be great, but until I get a full-time triage nurse that sits out in the lobby, that's not going to happen at this time. So now that the registrar has announced that the patient has arrived, triage nurse acknowledges over the walkie-talkie and then promptly goes to get the patient. We do a pull to full in our ER, so if there's an open bed, they don't go to a triage location, they go directly to the room. In the room, the nurse starts her assessment and then initiates nurse ordered protocols. A lot of those have labs that are involved with them. Then they go and they make a call to the lab for a stat draw, and then the lab shows up, and if the IV is not started by the nurse and labs have been drawn off, they will do a straight stick, which is, again, both of those times there's a lot of improvement for turnaround time. If our provider was able to swarm, we would have all of our orders at the beginning, but oftentimes they can't, so then they will put any new additional orders in, and sometimes there are additional lab tests that we will have to have reordered or sometimes redrawn. The patient care is going to continue while we're pending all of those lab tests, which is, of course, the biggest part of our stay. Labs are resulted, the provider evaluates, and then makes a decision. Once the decision is made to either admit, transfer, or discharge, the nurse then acts, and then the patient is either admitted, transferred, and discharged. That's our current state. There's just a little bit of variation on my future state, which is the next slide. As you can see, there's now a gap in the middle between the time that the patient was announced and the time that the labs are in process. So in the future world, we would like that the lab staff carries a walkie-talkie as well, and that as soon as they hear a chief complaint that they know has labs associated, they just immediately respond to the ER and are at the bedside drawing the labs through a straight stick while the nurse is still getting their triage assessment. That's going to cut off a huge amount of time for us. And even if we can only shave off 10 minutes, that will make us get to our turnaround time goal. And that's really the only change that I made on this slide, is just getting the lab in there right away without us having to call them or for them having to wait for us to start the IV. So we want to share our results. So there's lots of ways that we can do this, and there's lots of ways that we already plan to do it. So results are reported at the daily safety huddle. I already report lab turnaround times as well as the ED disposition times. We have our patient flow team council. There's the ED unit council. Each of us has action plans that are 30-day action plans that report at quality and safety council. There's our monthly leadership evaluation manager goals, which I've already spoke about. We have to update our action plans every month with that and review those with our chief executive officer to make sure we're on board with everything. Weekly at the ED lab turnaround time throughput strategic business initiative. We call them SBIs here. That's a lot of words to say. We have a weekly team meeting where the lab and ED meet to discuss, and all these key team players are there. We have our department staff meetings monthly, and then we also have strategic alignment boards in every department where we post our results. Lots and lots of references here. Some of them are a little bit older, but I also have much more current ones. Thank you for listening to my program, and I hope somebody else can benefit from this as well. Have a great day.